So we'll move on to our next speaker, who is a podium presentation. So Prashant Velayudhan, hopefully I didn't massacre that too much, who is from the Hospital for Sick Children in Toronto, who's going to talk about biopsychosocial subtypes of pediatric concussion, predict behavioral impairment. Prashant is a second-year PhD student in Dr. Ann Wheeler's lab in the Neurosciences and Mental Health program at the Hospital for Sick Children and the Department of Physiology at the University of Toronto. His research focuses on applying computational methods to better understand the heterogeneity of concussion. Welcome.
Let's get a little stopwatch going. Okay, so hi everyone. I'll just start with some acknowledgements. So thank you to my supervisor, Dr. Ann Wheeler, some collaborators in and outside of our lab, as well as funding from the Hospital for Sick Children, the Government of Ontario, and the University of Toronto, as well as the Precision Child, Youth, and Mental Health Initiative at C.E.T.S. So pediatric concussions, we know, can cause very diverse and very long-lasting impairments. So there are a wide range of cognitive, somatic, and behavioral impairments that can follow a concussion, which may last for days or months or years after an initial injury. The stat I have here is that approximately 10% of children in Canada sustain a concussion each year. So it's very prevalent. And we know that our ability to predict what symptoms a child is going to experience, how long those symptoms are going to last, and how best to manage those symptoms isn't as good as it could be. So one of the difficulties with concussion and pediatric concussion is that we know that so many injury and patient and environment factors can all influence what kind of outcomes can occur following a concussion. But children are very heterogeneous across all of these factors, which makes it very difficult to understand, how each of these variables relate to each other to give rise to a specific outcome. We know from other heterogeneous disease contexts like cancer that subtyping or cluster analysis can be really useful for this sort of problem, where we take a heterogeneous population, divide them up into less heterogeneous subpopulations, and then work on those subpopulations a little bit more independently. Now, many previous studies have tried using cluster analysis or have done subtyping in concussion populations before, but have shared a couple of kind of common challenges. So one has to do with having a limited breadth of input data. So again, a wide range of input variables can influence the concussion outcome, but most concussion data sets don't really cover this wide breadth of possible factors that influence concussion outcomes. And another problem is that most clustering algorithms are not really well suited for integrating really diverse and high dimensional types of data. Another kind of common difficulty is with external validation. So a lot of these studies will find interesting patterns in the subtypes that they put together. But it becomes a little bit unclear how well these patterns are going to generalize to patients who are not part of their actual starting data set. So this table, it's very tiny text. It's coming from a systematic review that we're working on, and each row is a different study that has looked at subtyping concussion. And in the middle column, a green check mark is there anytime the study did any form of external validation. So usually what this means is that they would set aside some variables that they don't include in their clustering algorithm. And then they find their subtypes of concussion. And then they check to see if the subtypes they found are significantly different according to the kind of variables that they had set aside. Now, this isn't the most rigorous approach to external validation, because if their set aside variables correlate in any way with any of the things that they fed into the clustering algorithm, which usually they do, you can kind of expect a bit of a guarantee that these subtypes are going to be significantly different according to their external validation variable. Now, a bit more of a gold standard approach to external validation is what's kind of shown on the rightmost column. And that's trying to see if you can replicate the findings from your subtyping analysis in patients who are not involved in your subtyping to begin with. And so only a couple of studies have tried to really do this, and both of those were in adult populations. So the main kind of objective of my project is to try and define and characterize these pediatric subtypes of concussion while taking into account some of these difficulties. So we're using the Adolescent Brain Cognitive Development Dataset, which is a community sample. It contained about 11,000 kids between the ages of 9 and 10. Around 320 of them have sustained a previous concussion. And so just some summary about the data set. We have about 60% of them are males. Most of them did not experience any loss of consciousness following their injury. Most of them did feel either dazed or had some sort of memory loss following their injury. This data is all, the TBI data is all collected using the Ohio State TBI screen, if you're familiar with that. So as far as what information we get about injury mechanism, there's kind of this large chunk of children who have this generic injury acquired method is somehow through a visit to the ER is what we know about them. And then there's this other chunk of kids who've gotten their injury through a fall. And as far as race goes, about a quarter of the kids are white, 10% Black, and then the rest fall into this large mixed or other cohort, which starts becoming extremely small when further stratified. Now, for the variables that we've thrown into our clustering, we're looking at a wide range of acute injury information, some structural, functional, and diffusion imaging measures, a variety of demographic factors like pubertal status and household income, some psychosocial resilience factors such as family environment and parent psychopathology, which have been increasingly shown to play or strongly associate with post-concussion outcomes, as well as a couple of medical history variables, so their history of MTBIs and their history of headaches. We have kind of a main set of outcome measures that are not directly being included in the clustering itself, and these are behavioral measures based on the child behavior checklist. So to do our clustering, we're using a fancy technique called similarity network fusion. And the way this works is that each kind of variable that we have gets converted into its own similarity network or similarity matrix. And this network kind of describes how similar all of the patients are to each other according to this one variable. Then the SNF or similarity network fusion algorithm, it takes all of these networks and kind of combines them into some sort of average network. And that network should describe how similar all the patients are to each other across all the variables. And then we can slap on a clustering algorithm to that network and find our subtypes of concussion. And empirically, this process has been shown to really preserve a lot of the signal to noise ratio in your starting data compared to other techniques like hierarchical clustering or K-means. So to do our external validation, we're using a technique called label propagation. And so how this works is we're going to set aside some kids who will not be used in the clustering at all. And we're going to calculate how similar those kids are to the kids who have received a subtype already. And when we have that information of how similar you are to the people who already have a known subtype, that's kind of all the label propagation algorithm needs to basically predict what subtype you would have belonged to if you were part of the clustering. And from there, we can try and see what kind of patterns still hold in these propagated solutions. So the overall experimental design is we're going to take our children, we're going to divide them into this 80% training split and 20% testing split. We're going to look at a lot of different clustering solutions in our training set by kind of varying different clustering settings. And we're going to take the best clustering solution, which we'll define to be the clustering solution that does the best job of separating kids out according to their behavioral measures. Keeping in mind that these behavioral measures aren't directly an input in the clustering itself. And then finally, we're going to generalize how well the clustering solution kind of generalizes in our held out 20% of kids using label propagation. So what we find, and there's no stats here, this is all in our training set where we kind of looked at a billion trillion different clustering solutions. And so these are just 4 of the CBCL measures related to depression, anxiety, attention, and aggressive behavior. And blue indicates no problem. Green is borderline clinical behavioral impairment, and red is clinical behavioral impairment. And so what we see is we have this kind of high behavioral impairment cluster, which is cluster 1, that's the bar on the left, and this low behavioral impairment cluster, that's cluster 2, which is the bar on the right. And just a few of the inputs, variables that went into the clustering, seeing how the two clusters kind of separated out according to that. So we see our high impairment group in general has a more advanced pubertal stage. They tend to have, they have a higher proportion of kids who come from a lowest income family. So blue is like the lowest grade out of our 3 income grades. It's a little subtle, but there's slightly less participation in extracurricular activities in this high impairment group. And then also a little subtle, there's a slightly higher proportion of females in the high impairment group, you know, which is kind of lines up with what's being shown in terms of being female being a risk factor for worst outcomes following a concussion. And then some interesting kind of MR findings. So what's going on with these heat maps is each row is a different brain region, and each cell, the cells are very, very tiny, but each cell is the average value for that brain region across all children in that subtype. And then these have all been kind of scaled such that whichever cell was the highest value gets assigned a value of 1, which becomes very red, and everything else kind of gets scaled down accordingly. And the takeaway from these heat maps is just that in this particular partition of the data, we can see that the high impairment group had lower cortical surface areas and lower subcortical volumes across almost all regions compared to the low impairment group, despite this high impairment group being in general at a higher pubertal status. And then now when we take a look at our kind of label propagated solution to see how well do these patterns generalize to our children who weren't involved in the clustering, we see kind of nice split again of these high impairment and low impairment clusters, even though the behavioral measures were not involved in calculating the similarities between patients and they weren't involved in the clustering. We see, you know, similar trends in terms of the other inputs I have previously discussed, and some similar trends in terms of the MR as well. So some future directions that we're interested in are taking a look and seeing if traditional clustering approaches can pull apart these subtypes as well. Taking a look and seeing if these subtypes will be useful for kind of predicting longitudinal outcomes, because we do have some longitudinal data in this data set, and then determining how specific our subtypes really are to concussion as opposed to just kids who are this age right now. But some conclusions is that we've defined these subtypes of pediatric concussion. We found a well-separated 2-subtype solution that was kind of driven by some of the variables I mentioned before. We very rigorously showed that this solution was able to generalize well to kids who weren't involved in the clustering. And we identified a few variables which may be particularly relevant to post-concussion behavioral impairments. So thank you.
Any questions?
Thank you. Great talk, and really appreciate the rigor of your work. So the MRI findings are a bit alarming for concussion population to see these positive findings. I'm sure you thought about this. How confident do you feel that they're acquired? And is it possible that these are premorbid differences between the?
It's possible that it's premorbid differences, and I think that's something that we're going to be able to find out a little bit better with our next work. So right now, this is all in baseline data, where it's basically these group of kids who have had a concussion in the past. But we also have a set of children who didn't have a concussion at baseline, but they did have a concussion at between baseline and like a 2-year follow-up time point. We have MRI for both of those time points. And so that's where we're going to really like dive in and learn more about that question there.
Great. Thanks.
There's a question online. Clustering is an unsupervised learning strategy So we usually don't have test data. We might have validation data though.
Mhm.
Meanwhile, how do you decide about the number of clusters?
Right. So, okay, so I guess there's two things there. So as far as number of clusters go, in this case, I mean, different clustering algorithms, some of them require you to specify how many clusters you believe there to be. Some of them will tell you how many clusters the algorithm thinks there are. So this is one of those kind of pipelines that tells you how many clustering algorithms it thinks there are. I think one of the important things about clustering is that there's not really one solution for a data set. There's usually many ways to like slice and dice the data and get different clusters that teach you different things. That's why we tried to do this approach where we're specifically seeking out a clustering solution that separated kids apart by behavioral impairments, so that when we go in and characterize that solution, we can learn more about things that might be particularly relevant to behavioral impairments. And then regarding clustering being like an unsupervised learning problem, that's absolutely true. And I think that this is one of the tough things is like, you know, very in like a very original sense of applying clustering. It was purely for exploration, just like unguided exploration of data. And that's why you wouldn't have any sort of testing or anything like that. But increasingly, as clustering gets adopted for, you know, clinical interpretations of things, we're starting to see this unsupervised learning approach being used to make inferences about the population at large. We're not just interested in like, okay, we've divided our data into subtypes. That helped us learn about our data. What we're doing is we're dividing our subtypes into our data into subtypes and trying to say, this teaches something about everybody who's ever had a concussion. And when we start doing that and we're trying to infer things about people not involved in our data set, then it's really important to have a set aside external validation set for us to be confident in the conclusions we're drawing from our analyses.
Thank you so much.